Hey guys, it's Mrs. Page, and today we are going to be talking about biliary disorders. A little bit of an overview of the biliary tract. So the biliary system includes the liver, gallbladder, and pancreas. The biliary system secretes enzymes and other substances that promote food digestion in the stomach and the small intestine. These disorders can extend to other organs because of the close anatomic location if they're not treated early. And inflammation and obstruction can occur in the biliary system from gallstones, edema, stricture, or tumors. You can see here that there is the common bile duct that the liver drains into. You've got the cystic duct that the gallbladder drains from, and then the pancreatic duct that the pancreas drains from, and then they all connect into one and they drain into the small intestine. So that's important to remember when we're talking about our biliary tract disorders. Cholecystitis is inflammation of the gallbladder. There are different types of cholecystitis. There's acute and chronic. There are different types of acute cholecystitis. There's calculous cholecystitis, which is chemical irritation and inflammation that results from gallstones, which is cholelithiasis, that obstructs the cystic duct, the gallbladder neck, or the common bile duct. So the trapped bile is reabsorbed and circulation is impaired, and the gallbladder becomes distended, which causes ischemia and infection. This leads to tissue death, and the gallbladder can eventually perforate, which will lead to an abscess formation or peritonitis. Abnormal metabolism of cholesterol and bile salts are thought to be the cause of gallstones. Acalculous cholecystitis is inflammation of the gallbladder without gallstones. This is caused by any condition that affects the regular filling or emptying of the gallbladder, such as sepsis, severe trauma or burns, long-term TPN, multiple organ dysfunction, major abdominal surgery, or hypovolemia. Chronic cholecystitis is repeated episodes of cystic duct obstruction, which causes chronic inflammation. Calculi, or the gallstones, are almost always present. The gallbladder becomes fibrotic and atrophied, which results in decreased motility and deficient absorption. This is common in young, thin women, people who have a low-fat diet, so specifically vegetarians. Complications can include pancreatitis and cholangitis, which is bile duct inflammation from the backup of the bile through the biliary tract. Jaundice and icterus, which is the yellowish coloration of the eye sclera, are more common in chronic cholecystitis than acute. There is obstructive jaundice, which is from the normal flow of the bile in the duodenum is blocked. So this can cause that obstructive jaundice. It can be intrahepatic or extrahepatic. Excessive bile salts accumulate in the skin, which leads to pruritus. Bile flow blockage also prevents bilirubin from reaching the large intestine, where it's converted to urobilinogen, which urobilinogen causes stools to have their brown color. So as a result from this blockage, stools are clay-colored and the urine becomes dark because of the kidney's effort to clear the bilirubin. Assessment for cholecystitis. Risk factors are the 4 F's: female, 40, fat, and fertile. Females are going to be at a higher risk for cholecystitis. The risk increases with age, it increases with obesity, and women on birth control pills, pregnant, or hormone replacement drugs will also be at a higher risk because these delay the muscular contraction of the gallbladder, which decreases the rate of emptying. American Indian, Mexican American, or Caucasians are at a higher risk. Excessive dietary cholesterol intake or cholesterol-lowering drugs, family history of gallstones, and this is specifically related to the nutrition habits that someone gets from their family. Prolonged TPN, Crohn's disease, sickle cell disease, and diabetes also puts this patient at a risk for cholecystitis. History, you want to obtain a height, weight, and vitals. Ask about their food preferences, specifically diets high in fat, calories, white carbohydrates, and low in fiber. These are going to put the patient at a higher risk. Low-fat diets can contribute to the chronic cholecystitis in young, thin women. Ask about GI symptoms such as flatulence, dyspepsia, indigestion, anorexia, nausea, vomiting, or abdominal pain. Ask the patient to describe daily activities or the exercise routine. Ask about family history and medications, specifically the hormone replacement therapy or oral contraceptives. Physical assessment, signs and symptoms. They're going to have abdominal pain in the right upper quadrant that can radiate to the right shoulder or scapula. This is often referred to as gallbladder attacks in patients with chronic cholecystitis. With chronic cholecystitis, they'll have jaundice, clay-colored stools, dark urine, icterus, steatorrhea from the decreased fat absorption. The advanced physical assessment reserved for the advanced practice nurse or doctor. There is rebound tenderness rebound tenderness called the Bloomberg sign, and deep palpation below the liver border in the right upper quadrant. Might feel sausage-shaped mass, which is the distended, inflamed gallbladder. Labs and diagnostic tests for cholecystitis. Increased white blood cell count indicates inflammation. AST, ALT will be increased, and serum bilirubin levels will be elevated. Diagnostic test. Abdominal x-ray, possibly. An ultrasound is going to be the best initial test for cholecystitis. The HIDA scan, which is the hepatobiliary aminodiacetic acid scan, or an ERCP, endoscopic retrograde cholangiopancreatography, or MRCP, which is the MRI version of an ERCP. And possible nursing diagnosis for cholecystitis can be acute pain or chronic pain related to gallbladder inflammation, or imbalanced nutrients less than body requirements related to decreased intake because of pain, nausea, or anorexia. Interventions for cholecystitis, we've got nonsurgical, so managing the pain is going to be up there in priority. The pain only occurs when the gallstones are partially or totally obstructing the cystic or common bile duct. They should avoid fatty foods to prevent future attacks. Hold foods and fluids if nausea and vomiting is occurring. Give them IV fluids to prevent dehydration, and ketorolac or Toradol NSAIDs for mild to moderate pain. Promote nutrition. Diet should be high in fiber and low in fat. Avoid gas-producing foods, and small, frequent meals are best. They might need antiemetics for nausea and vomiting, IV antibiotics, oral bile acid dissolution or gallstone stabilizing agents, extracorporeal shockwave lithotripsy or ESWL. This is when shock waves are used to break up the larger stones into smaller ones so that they can be passed easier. There's also a percutaneous transhepatic biliary catheter or a drain so that the bile can flow. It can be internal or external, and it can be temporary or permanent. You can see here, this is the catheter that they might insert. Surgical management is going to be a cholecystectomy. It can be laparoscopic or an open approach. They're going to have a general pre-op preparation. The laparoscopic approach, which is the one that's most commonly done, an abdominal incision is made. The abdominal cavity is filled with 3 to 4 liters of carbon dioxide. The gallbladder is dissected from the liver and removes the gallbladder through the umbilical puncture site. You can see here, this is the laparoscopic version. Post-op, they want to do early ambulation to help get rid of that extra CO2 from the abdominal cavity. They might need antiemetics, analgesics. They can advance the diet as tolerated while avoiding fatty foods. Normal activity can resume in about 1 week. For the open approach, this is usually reserved for severe obstruction. The incision is going to be in the right upper quadrant, and a drain will usually be in place to prevent fluid accumulation. You can see here, this is the open approach. Postoperatively, they should worry about controlling pain, antiemetics, incision care, surgical drain care. They'll be NPO until fully awake. Clear liquids to solid foods as peristalsis returns. Complications for the open approach is the post-cholecystectomy syndrome, and this is where there is repeated abdominal pain and epigastric pain with nausea and vomiting. And then they'll do an ERCP to find the cause and repair it. And priorities are going to be pain control, hydration, controlling the nausea and vomiting, and administering antibiotics. Next, we'll talk about acute pancreatitis, which is a serious and life-threatening inflammation of the pancreas. Remember, the pancreas has exocrine and endocrine functions. The primary exocrine function is to secrete enzymes that help break down starches, proteins, and fats. Enzymes are normally secreted in an inactive form, and then they become activated in the small intestine. Early activation, meaning the enzymes are activated while they're still in the pancreas, is what causes the inflammation of the pancreas, the pancreatitis. Early activation can be caused from obstruction of the pancreatic duct. Causes of acute pancreatitis: biliary tract disease, usually gallstones or pancreatic obstruction, trauma from surgical manipulation or blunt trauma, viral infections such as Coxsackie virus B and HIV, metabolic problems like hyperlipidemia, hyperparathyroidism, or hypercalcemia, alcoholism, toxicities of drugs, cigarette smoking and tobacco use, or cystic fibrosis. Risk factors include holidays when alcohol consumption can be high. It's more common in women and more common after giving birth, and older adults have a higher rate. Complications can include jaundice from the swelling of the pancreas, which slows down bile flow through the common bile duct. Can also be caused from the total obstruction of the bile duct from stones or a pseudocyst. Type 1 diabetes from the destruction of the pancreas. Left lung pleural effusions, atelectasis, pneumonia, or acute respiratory distress syndrome. Multi-system organ failure from necrotizing hemorrhagic pancreatitis. And coagulation defects such as disseminated intravascular coagulation, or DIC. Assessment for acute pancreatitis. First, you'll do a history. Ask them about their abdominal pain. Is it severe and constant? Ask them about risk factors such as alcohol consumption, high-fat diet, family history, biliary tract disease, GI surgeries, medical problems known to cause pancreatitis, and all prescription and over-the-counter drugs. Physical assessment and signs and symptoms is going to depend on the severity of inflammation. Severe abdominal pain in the mid-epigastric area or left upper quadrant with a sudden onset. It can radiate to the back, left flank, or left shoulder, and it will worsen when lying in a supine position. They can have weight loss from nausea and vomiting. An abdominal assessment will reveal possibly a gray-blue discoloration on the abdomen and peri-umbilical area, which is called the Cullen sign, you can see here. A grayish-blue discoloration of the flanks from pancreatic enzyme leakage into cutaneous tissue, which is Turner sign, you can see here. Bowel sounds you want to listen to. They might have abdominal tenderness, rigidity, and guarding, and also auscultate the lung sounds. With pancreatitis, there is going to be a lot of inflammatory chemicals that are secreted into the bloodstream, and these chemicals can create inflammation throughout the body, including the lungs, which is where you will get the respiratory complications. Psychosocial assessment specifically asks them about their alcohol intake history because that can be a cause of this acute pancreatitis. Acute pancreatitis labs and diagnostics. Increased amylase. This will be an acute increase, and increased lipase. And lipase will stay elevated for a longer period of time. Trypsin and elastase will also be elevated. Increased bilirubin, ALT, AST if the liver is involved. Elevated glucose, white blood cell, and ESR. And decreased calcium and magnesium from fat necrosis. Diagnostic test, a CT with contrast. And you can see here in this CT, it shows that the pancreas is inflamed and edematous. An abdominal x-ray might be done, an ERCP, or an abdominal ultrasound to help diagnose the cause of pancreatitis. Interventions for acute pancreatitis, non-surgical is assess and support, ABCs, pain assessment, NPO to rest the pancreas and reduce enzyme secretion. They'll need IV fluids to maintain that hydration while they're NPO. Opioids for pain. Histamine receptor antagonists to help decrease gastric acid secretion. Antibiotics. They might be in the side-lying fetal position to help decrease pain. Oral and nasal hygiene is important, especially if they have an NG tube. Monitor for hypocalcemia. Nutritional support. After the initial stage is over, they will start on enteral feedings. Small, frequent, moderate to high carbohydrate, high protein, low fat meals during the healing stage. So they should have the meals should be bland with little spice. They should avoid GI stimulants, and they might need a commercial liquid nutritional replacement such as Ensure or Boost. Surgical management will be a cholecystectomy if the ERCP is not successful and gallstones is the cause of pancreatitis. It also might require surgery to remove the pancreatic pseudocyst or abscesses, so it just depends on what is causing that pancreatitis. Home care is going to include nutritional support and support groups if they have alcoholic pancreatitis. Chronic pancreatitis is the progressive destructive disease of the pancreas that has remissions and exacerbation. There's different types. There is chronic calcifying pancreatitis, which is when the pancreatic secretions plug the pancreatic ducts and the flow of the juices. So that causes calcification of the ducts and tissue destruction. This is the most common type, and the primary risk factor is alcoholism. Chronic obstructive pancreatitis develops from inflammation, spasm, and obstruction of the sphincter of Oddi. The sphincter of Oddi is the muscular valve that controls the flow of digestive juices through the ducts from the liver and pancreas into the first part of the small intestine. So it causes chronic obstructive pancreatitis, causes obstruction and the backflow of pancreatic secretions. There's also autoimmune pancreatitis caused from immunoglobulins that invade the pancreas, and idiopathic and hereditary chronic pancreatitis, which is associated with gene mutations. You can also see here on the right side, this is a comparison of acute pancreatitis versus chronic pancreatitis, and there are different signs and symptoms, so it's important you know the difference between those. Physical assessment of chronic pancreatitis. They will have continuous burning or gnawing pain with periods of exacerbations, abdominal tenderness, pancreatic ascites, auscultate lung fields for adventitious sounds, observe for dyspnea, steatorrhea or clay-colored stools from fat malabsorption, weight loss from fat malabsorption, jaundice, dark urine, and signs of diabetes. Lab tests will be the same as acute pancreatitis. Amylase and lipase will be normal or moderately elevated. The serum bilirubin and alkaline phosphatase levels will be elevated, and glucose will also be elevated. Diagnostic tests will be ERCP to visualize the pancreatic and common bile ducts, and possibly a CT scan, MRI, or abdominal ultrasound. Interventions for chronic pancreatitis. Non-surgical will include pain control, nutrition. More than likely they'll be on TPN, and they will need to receive 4,000 to 6,000 calories per day, and they will avoid alcohol and high-fat foods. They might receive pancreatic enzyme replacement therapy, or PERT, P-E-R-T. If your client is receiving this type of therapy, you should monitor the stools and characteristics so that you can monitor effectiveness of this therapy. If the pancreatic enzyme replacement therapy is effective, the stools are going to become less frequent and less fatty. They should take these with meals and snacks and follow with a glass of water. They might also receive drug therapy to decrease gastric acid because gastric acid destroys lipase that is needed to help break down fats. Surgical procedures, this is not the primary intervention, and the underlying problems that are causing the chronic pancreatitis is going to determine the surgical procedure. So if biliary tract disease is the underlying cause of pancreatitis, then they might have a cholecystectomy. If the pancreatic duct has fibrosis, then they might have a sphincterotomy. If there is necrosis of the pancreas, they might have a pancreatectomy, or they might need a pancreatic transplant. Home care. These patients are very weak when they go home with chronic pancreatitis, so they might need to be on or they might need to live in a house that has one floor or a floor that has everything that they need because they have limited strength. They also need to be close to the bathroom because they will have to use the bathroom a lot. Provide information on nutrition therapy, skincare, drug therapy regimen, and support groups because this is a long-term disease. Lastly, we'll talk about pancreatic cancer. This is most often discovered in the late stages of development. Treatment has limited results, and the 5-year survival rates are low. The tumor might be the primary cancer, or it may result from metastasis from cancers of lungs, breast, thyroid, kidneys, or skin. Risk factors for pancreatic cancer are going to include diabetes, chronic pancreatitis, cirrhosis, high intake of red meat, especially processed foods, long-term exposure to chemicals like gas or pesticides, obesity, older age or male, cigarette smoking, and family history or genetic mutations. Assessment and signs and symptoms are going to depend on the site of origin and metastasis. The head of the pancreas is the most common site. Symptoms will often present in a slow and vague manner. Symptoms will include jaundice, icterus, clay-colored stools, dark urine, abdominal pain that radiates to the back, weight loss, anorexia, nausea, vomiting, splenomegaly, flatulence, GI bleeding, new onset diabetes, ascites, and weakness or fatigue. Labs and diagnostic tests. There's no specific blood test for pancreatic cancer. Serum amylase, lipase, and bilirubin might be elevated, and they might have elevated CEA or carcinoembryonic antigens. Diagnostic test, abdominal ultrasound and a CT with contrast, an ERCP, percutaneous transhepatic biliary cholangiogram with a placement of a drain to help decompress the blocked biliary system if that's what's causing pancreatic, or if that's one of the complications of pancreatic cancer. And aspiration of the pancreatic ascites fluid can reveal cancer cells in it. Pancreatic cancer interventions. Complications of this can include venous thromboembolism because the necrotic products of the tumor have thromboplastic properties, and the patient also has decreased mobility from lying in the bed and being weak. Interventions, nonsurgical. Chemotherapy and radiation can help relieve pain and shrink the tumor. They will have pain controlled with morphine usually, and biliary stents can help relieve pain from obstruction. Surgical, there is the partial pancreatectomy for smaller tumors. There is the radical pancreatectomy for larger tumors, and there is also the Whipple procedure, which we will talk about on the next slide. The Whipple procedure removes the proximal head of the pancreas, duodenum, a portion of the jejunum, the stomach, the gallbladder, and it reattaches it to the pancreatic duct, common bile duct, and the stomach to the jejunum, and it can also remove the spleen. Preoperatively, they might have a jejunostomy tube for feeding. They might also have TPN in addition to tube feedings, and they will be NPO for 6 to 8 hours prior to the surgery. Postoperatively, they will be NPO with an NG tube and biliary drainage tubes. Make sure you monitor the drainage and patency. They will be in a semi-Fowler's position to reduce tension on the suture line. They'll receive IV fluids, so you should monitor their electrolytes. If they need insulin, administer that. Monitor for bowel sounds. Complications of the Whipple procedure would be development of fistulas, peritonitis from pancreatic enzyme or gastric content leakage into that peritoneal cavity, blood loss, electrolyte imbalances, or infection. Home care is going to be providing emotional support and family support because they will need to be taking care of this patient. Help the patient prepare for death, so help them set up their living will, help them visit with friends, call the priest or preacher, whoever they would want to talk to. And then they might need home health or hospice care or palliative care. So that's all I have for biliary disorders. If you guys have any questions, feel free to reach out to me, message me on Teams, and bring some questions to the Q&A sessions.